Thanks everybody for joining us in person and online. Today we have a talk given by Dr. Muponda from Cardiology on HFpEF. For those students potentially in the background who don't know yet, HFpEF stands for heart failure with preserved ejection fraction, which is a fairly broad term and probably encompasses quite a large number of pathologies. The characteristic is what we term diastolic heart failure, but it isn't actually synonymous with diastology. So Dr. Muponda is going to take us through this topic and also the very relevant new management therapies that are available currently.
Morning, colleagues. Yeah, so I'll be taking you through heart failure with preserved ejection fraction. So I have no disclosures related to this topic I'll be presenting today. Okay, so the outline of this presentation will start with a clinical case, definition and classification of heart failure in general, and definition of heart failure with preserved ejection fraction. We'll also look at the epidemiology, pathophysiology, diagnosis, and treatment. So start with our clinical case. So Mr. MS 003 is a 71-year-old male with a background history of RVD. He's diagnosed 8 years ago. His CD4 count is preserved. He's got a viral load that is undetectable on TOD. Doesn't have any history of opportunistic infections. He's also hypertensive for at least 10 years and has been on reduc. And has got target organ damage in the form of LVH. So he presented with a 2-month history of progressively worsening two-pillar orthopnea, bilateral lower limb swelling, abdominal swelling, PND, pleuritic chest pain associated with a non-productive cough. On examination, he had a normal blood pressure and a heart rate of 83. Sets were 92% on room A, and he had a BMI that was raised at 32 kgs per square meter. His cardiovascular exam reviewed a raised JVP, normal S1, S2, and a third heart sound, and no murmurs. He had bilateral pleural effusions and scattered crepitations on examination, abdomen, he had ascites. The other systems were unremarkable. ECG showed low voltage complexes and sinus rhythm, and you can also appreciate the right axis deviation. His chest X-ray showed bilateral pleural effusion and a raised cardiothoracic ratio. And then his echo, you can appreciate the preserved LV systolic function, the concentric LVH, and he had a biplane ejection fraction of 52% with LVIDD of 37 millimeters, LVIDS of 26, and an LA diameter of 44, and left ventricular hypertrophy as evidenced by the intraventricular septal diameter of 21. Also had, you can appreciate this mild mitral regurgitation, and on the subcostal view, you can appreciate the biatrial enlargement and also right ventricular hypertrophy and left ventricular hypertrophy. He had mild tricuspid regurgitation and had a TRV max of more than 28 centimeters per second. And he had grade 3 diastolic dysfunction evidenced by the very steep deceleration time with an E/A of at least 3, signifying a restrictive filling pattern, and an E/E prime of 16, signifying very high filling pressures. Okay, his right-sided function was reduced, showing a TAPSE of just still preserved at 18 and RVS velocity of 8. And his global longitudinal strain, his strain was also reduced with a strain of -9.3, although the pattern didn't really follow any specific patterns. Sorry. Okay, so his blood investigations, he had a normal UNE, normal FPC, He was pre-diabetic with an HbA1c of 6.2. And his wake up for plasma cell dyscrasias was negative, and he had a very elevated NT-proBNP of 5,809, and his high sensitivity trop was 37. And then we calculated his H2FpEF score. So he had 2 points for a BMI more than 30, a point for hypertension, a point for pulmonary hypertension, and since he's 71, also he had a point for his age, and his E over E prime was 15. So his total score was 6, which is diagnostic of heart failure with preserved ejection fraction. On the HFpEF score, he scored a total of 6 points, which is also diagnostic of heart failure with preserved ejection fraction. Okay, so he had an MRI since the differential diagnosis on admission. There was a strong suspicion of cardiac amyloid. So they did an MRI. Unfortunately, we don't get physical reports. The verbal report was we should pursue amyloidosis. So since the wake-up for AO amyloidosis was negative, we pursued the pyrophosphate scan to rule out ATTR amyloidosis, which also came back as negative. So the diagnosis after all these investigations was heart failure with preserved ejection fraction. Patient was recruited for the MS trial. Any questions so far in this case? Okay, so next we start our presentation. Sorry, how do you remove this thing here? Take this to the side. Oh, okay. So what is heart failure? So the definition of heart failure has been evolving over the past 150 years. So one of the great Scottish cardiologists, Sir Mackenzie, in his publication in the Oxford medical publication titled Disease of the Heart in 1908, he defined heart failure as a failure of the reserve force of the heart. That was in 1908. So this definition, as you can see, it has been evolving over time, and they've been adding more sentences and more paragraphs since it was defined in 1908 by Sir Mackenzie. One of the ones that I like is by the father of modern cardiology, Professor Eugene Branwald himself, who defined it in 1980 as heart failure is a pathophysiological state in which an abnormality of the cardiac function is responsible for the failure of the heart to pump blood at a rate commensurate with the requirements of metabolizing tissues. Okay, so currently, the current iteration of the ESC guidelines define heart failure as a clinical syndrome consisting of cardinal symptoms like breathlessness that may be accompanied by signs, for example, elevated JVP, and it is due to a structural and functional abnormality of the heart that results in elevated intracardiac pressures and inadequate cardiac output at rest or during exercise. So the Framingham criteria, which were derived from the Framingham study, are commonly used to diagnose heart failure. Okay, so they have a sensitivity of 100% and a specificity of 78%. So you need at least 2 major criteria, or 1 major criteria and 2 minor criteria to diagnose heart failure using the Framingham criteria. Okay. All right. So this table, I took it from the American Heart Association guidelines for heart failure. So in contrast to the ESC guidelines, the American Heart Association employ a distinct classification for heart failure. So they categorize heart failure into these 4 stages, which is stage A, which encompasses individuals that are at risk of heart failure, and stage B, which are patients with pre-heart failure, In stage C, which are patients with symptomatic heart failure. In stage D, which are patients with advanced heart failure. Okay, so the usefulness of this staging system is in prognostication. So patients with stage D heart failure tend to have a horrible mortality rate, and most of them have got an expected life expectancy of up to 6 years. Okay. Similar to the ESC guidelines, though, to the American Heart Association guidelines, the ESC and the American Heart Association, they classify heart failure using the universal definition of heart failure, which classifies it using ejection fractions. There are, although, other ways to classify heart failure. Of course, you can classify it by the location, whether it's left-sided or it's right-sided. The time course, whether it's new onset or it's chronic or it's transient, and its progression over time, whether it's acute, whether it's stable, or it's worsening. But the universal definition uses your ejection fraction. So heart failure with reduced ejection fraction is defined as an ejection fraction less than 40%. Heart failure with preserved ejection fraction is defined as an ejection fraction more than 50%. And heart failure with mildly reduced ejection fraction is an ejection fraction between 40 and 49. And then heart failure with recovered ejection fraction is those patients that had an ejection fraction that was below 40% previously, but now it's above 40%, or it has improved by at least 10 points. The significance of this last classification of recovered ejection fraction is when you treat those patients, even if they end up getting an ejection fraction of above 50%, but as long as they were below 40% before, we need to continue the medication for anti-remodeling because they tend to relapse after that. There is another proposed classification that they wanted to add there of heart failure with a supranormal ejection fraction, but they're still trying to characterize it. Okay. All right. So the definition of heart failure with preserved ejection fraction, the ESC and the American Heart Association are basically similar. So you need an ejection fraction above 50%. You also need to have clinical symptoms of heart failure and objective evidence of cardiac or structural and functional abnormalities of the heart, which simply just means either an echo or invasive testing. Okay, so the risk factors for heart failure with preserved ejection fraction, classically it was initially described in old patients that had hypertension, but now we know that you can get it in young obese patients. You can also get it in patients that are diabetic. Usually it's described as 30 to 40% of patients with heart failure with preserved ejection fraction and diabetes. It's also common in patients with sleep apnea, patients with chronic kidney disease, and patients that are physically inactive. Okay. So the pathophysiology of heart failure with preserved ejection fraction is a bit complex. So you start with your comorbidity conditions like metabolic syndrome and things like hypertension, type 2 diabetic, and renal insufficiency. These drive a pro-inflammatory state that is marked by raised inflammatory markers like your CRP, GD15. And this multisystemic inflammation involves multiple organs in the lungs. It tends to cause pulmonary hypertension. In the muscles, it tends to cause weakness. And in the kidneys, it tends to cause sodium retention. And in the heart, it causes microvascular dysfunction, and endothelial and cardiomyocyte signaling is affected. So the inflammation secretes something we call reactive oxygen species, which in turn lead to decrease in nitric oxide. And downstream there, you see there's also a reduction in your cyclic GMP and PKG. This leads in turn to hypertrophy and fibrosis. And also this process ends up leading to diastolic dysfunction, which is the hallmark of heart failure with preserved ejection fraction. Okay, so this graph here just tries to show you It was adopted from a study at the Mayo Clinic hospitals over a 15-year period between 1987 and 2001. So as you can see here, patients with preserved ejection, the prevalence has been on a steady rise since around 1986 there. It has been on an upward trend. Okay. And the proportion of patients with heart failure as a whole total of patients with heart failure, yeah, you can see there. So this was from the Framingham study. So between 1985 to 1994, you can see the green part there is patients with heart failure with preserved ejection fraction. And then the blue part of this paragraph is patients with heart failure with a reduced ejection fraction. So in between 1985 and the start to 1994, the numbers were almost equal, with HFrEF slightly outnumbering patients with HFrEF. But between 1995 and 2004, HFpEF slightly increased as compared to HFrEF in terms of proportion. But between 2005 and 2014, the number of patients with HFpEF in this study rose to 56% as compared to the ones with HFrEF, which was only 31%. Okay, so hospitalization for heart failure is the most common cause of hospital in patients that are above the age of 65. And more than 50% of patients with heart failure with preserved ejection fraction and okay, the prevalence is increasing, and more than 50% suffer from HFpEF in this proportion is significantly increasing. So approximately 30% of the patients with HFpEF die within 1 year of heart failure hospitalization. And previously we've had limited proven therapies, but it looks like the tide might be changing. Okay. So in terms of transitioning between the three classes of heart failure, this figure here was adopted from the CHART-2 study, which was a study where they recruited about 3,480 patients who had heart failure in Japan. As you can see there, from recruitment to 3 years, a significant proportion of patients with heart failure with a reduced ejection fraction transition to either HFpEF or heart failure with mildly reduced ejection fraction. So patients with HFpEF, as you can see, they transition, but to a different, but at a lower extent than patients with HFrEF and heart failure with mildly reduced ejection fraction. This Kaplan-Meier graph adapted from a study done by Mayo Clinic groups of hospital between 1987 and 2001, involving 4,594 patients, just shows that heart failure with preserved ejection fraction and HFrEF have similarly high mortality rates, as you can see there. In this study here, at 1 year, the mortality rate of HFpEF was around 29%, and that of HFrEF was 32%. And at 5 years, the mortality rate of patients with HF was 65%, and then the ones for patients with HFrEF was 68%. So the mortality rates are almost similar, with a slightly higher mortality rates in patients with heart failure with a reduced ejection fraction. So in terms of limitations of daily activities of daily living, patients with heart failure with preserved ejection tend to have worse limitation than the other subgroups of heart failure. As you can see, from showering to dressing, patients with heart failure, they often tend to report more limitation in these activities. Okay. In terms of hospitalization as a proportion of patients with heart failure, this study, which was adopted from the GWTG, from 2005 to 2020, you can see initially here, patients with heart failure with reduced ejection fraction on top there, the formed a significant proportion of patients that were hospitalized. But that changed around 2010 to 2011 there. And you can see there by 2020, the patients with heart failure were having a higher proportion of hospitalization compared to patients with HFrEF. Okay, so hospitalization accounts for around 80% of the total costs of heart failure with preserved ejection fraction, which is why if you check most studies on heart failure, their primary outcome endpoint is usually mortality and decreased hospitalization because of this very high cost. So this systemic literature search from 2001 to 2020 into a study that reported hospitalization costs. So the costs for index hospitalization range from a mean of $8,340 to $11,366 per admission for heart failure with preserved ejection fraction. And significant cost increase for patients with HFpEF and comorbidity versus patients with HFpEF alone. And the estimated costs of treating HFpEF per year was estimated to be around 27,174. Okay. So the diagnosis of heart failure is pretty challenging. We know that the gold standard for diagnosing HFpEF is rest and exercise, right heart catheterization, and then the figures that they quote when you do invasive testing or your hemodynamics is a rest pulmonary capillary wedge pressure of at least 15, and if it goes above 25 with exercise. Yeah, so there are these two scores that can be applied. You can't find hemodynamic testing at district hospitals, but echo is more readily available than invasive testing. So we have these two scoring parameters, the H2FpEF score and the HFpEF score. So the H2FpEF score was actually derived and validated using the gold standard of invasive exercise hemodynamic testing, and is more practical for clinicians. As you can see there, most of the parameters that you need are clinical. There is your BMI, your hypertension and atrial fibrillation, pulmonary hypertension, and your age. So only two of these parameters need you to have an echo, okay, which is more practical than the HFpEF score, which was derived from expert consensus and hasn't really been validated. So most guidelines actually prefer the H2FpEF score due to its simplicity and its practicality. Okay, so if you've got an H2FpEF score of at least 6, that's very high probability for it's at least 90% that you have heart failure with preserved ejection fraction. And if you've got an H2FpEF score between 0 and 1, it's unlikely. And then the patients that you would want to refer for invasive hemodynamic testing are patients with intermediate scores between 2 and 5. Okay, so those above 6, you treat as heart failure with preserved ejection fraction straight up. Okay. Okay, so when is HFpEF not HFpEF? So we have Mr. Jack, a 68-year-old male with stage 4 CKD, atrial fibrillation, lumbar spinal stenosis, and macroglossia, has got a BMI of 24. When you calculate his H2FpEF score, equates to the score of 6, but his echo is showing this hypertrophy, and his global longitudinal strain pattern here is showing this. Any of the registrars want to give a take on what they think it is? Any of the registrars? Dr. Kramer, can give it a shot. What do you think this is? Yeah, he's got a preserved EF, but he's got this history here. He's got a score of 6, missed the criteria for HFpEF, but he's got this echo here that we have seen here. Any takers? Yes, So this is the typical pattern we see in cardiac amyloid. We call it what? A cherry on top of a cake pattern there on GLS. So this patient doesn't have HFpEF. It's just a mimic of HFpEF. This patient has got cardiac amyloid, okay? All right. Okay, so it's crucial. I can't overemphasize that to exclude mimickers before you just say it's heart failure with preserved ejection fraction. It is actually believed in multiple case studies that up to 30% of patients who are diagnosed with heart failure with preserved ejection actually have cardiac amyloid. Yeah, in our setting here, due to the TB and HIV endemic, we will likely see a lot of patients with pericardial disease presenting with features of heart failure with preserved ejection fraction. Other common things that we see here, not so common, hypertrophic cardiomyopathy, cardiac sarcoidosis, hemochromatosis, and storage diseases like Fabry's, high output heart failure, and myocarditis. So you need to exclude all this before you definitely say this is heart failure with preserved ejection fraction. So essentially it's a diagnosis of what? Of exclusion, okay? All right, so in terms of treatment, the goals of treatment of patients with heart failure with preserved ejection fraction include prevention of hospital admission. Remember, we analyzed the cost. It costs around 27,000 around 6,000 per hospital admission, which is a bit too high. Then the second goal is to reduce mortality. Third goal is to improve clinical status. And the final goal is to improve quality of life and functional capacity. So there are a couple of trials that have been done over the past 10 or 15 years in patients with HFpEF. And most of these early trials that were done 10 years ago, they were trying to essentially import medication that was efficacious for patients with HFrEF into patients with HFpEF. But most of these trials dismally failed, okay? So as you know, the main pathophysiology of patients with HFrEF is the neurohormonal pathways, and most of those drugs that are used in HFpEF, they work to antagonize the neurohormonal pathways. And with HFpEF, it's completely a different story. Okay, it's mainly to do with inflammation. That's why most likely these trials were all negative. Okay, so one of the first trials that was done in patients with heart failure with preserved was the CHARM trial, which was published in the Lancet in 2003. It tested the angiotensin receptor blocker called candacetin. And as you can see there on the first part of this graph there, they said it modestly reduced heart failure hospitalization, but it was predominantly a negative trial. Similarly, they also tested this angiotensin receptor blocker called ebecetin. It also was a negative trial. And then the TOPCAT trial, which was published in the New England Journal in 2014, they tested spironolactone. And some reports will tell you that no, there was a decrease in hospitalization, but most guidelines will tell you that it was just neutral. So it also doesn't really appear in most guidelines. And then there was this trial called the Paragon trial, which tested the ANIS. Yeah, and they said there was borderline favorable results. Yeah, so the only drugs really that had a positive outcome were your SGLT2 inhibitors, okay? So the Emperor Preserve trial, which was published in the New England Journal in 2021, tested empagliflozin, and it managed to meet its primary endpoint, which is to reduce cardiovascular death and heart failure hospitalization. Similarly, in the same class of drug, dapagliflozin in the DELIVER trial in 2022, it managed to meet its primary endpoint, which is to reduce cardiovascular death or worsening of heart failure. Okay, so based on these trials on SGLT2, the 2023 focused update guidelines for the diagnosis and treatment of heart failure now have placed a class 1A indication for an SGOT inhibitor, whether it's DAPA or EMPLA, in all patients with heart failure with preserved ejection fraction to reduce hospitalization or cardiovascular death. Okay. The other class 1 medications that are recommended for HFpEF, it's your diuretics, which carry a class 1 indication, and also treatment of non-cardiovascular comorbidities as well. Yeah, this article from JAH by Kitterson and all, which was published last year in 2023, also has got this pathway that they use. Yeah, so besides an SGLT2, they've got these subgroups of patients based on subgroup analysis of all those trials that were on that page that I was describing. So they recommend for women, all women with HFpEF, and for men with EF less than 50, between 55 and 60, and those with fluid retention, you can add spironolactone. And then for all women and men with an EF between 55 to 60, you can also add an ANI. And for ANI-eligible individuals who cannot take due to costs or intolerance, you can add an ANI, but it doesn't appear in the main guidelines. Okay. Okay, so when you initiate these drugs, for dapagliflozin, your starting dose is 10 milligrams, and then your target dose is also 10. That's the dose that they were using in both the DELIVER and the empagliflozin, in the EMPEROR trial. Okay. So empagliflozin is also 10, and then the target dose is 10. And then for spironolactone, start at 25, and your target dose, you're targeting 50. And then for the ANIs, you're targeting 97 milligrams / 103 milligrams twice daily. And for candacetin, you're targeting 32 milligrams. So the general approach in managing heart failure with preserved ejection fraction, it causes you to confirm your diagnosis. And then you treat congestion with a loop diuretics. There is a trial where they were trialing furosemide versus torsemide. There was no really difference in mortality, whichever one you use between those two. And if the patient is at an EF of 50 and no prior heart failure with mild reduced EF or HFrEF, and you have excluded all those mimics that we described on that table, then you start them on guideline-directed therapy. So SGOT2, class 1A indication, and then exercise apparently improves quality of life, and also it's a class 1 indication as well. Okay. All right. So in the guidelines, they emphasize optimization of comorbidities. So the common comorbidities that we see in patients with heart failure with preserved ejection fraction is your hypertension. So the target blood pressure is 130/80. And for diabetes, first line medication for this patient should be an SGOT2 inhibitor. Okay. All right. And then for atrial fibrillation, some guidelines, some articles that I read, they were favoring rhythm control over rate control, but yeah, this one's saying rate versus rhythm control strategy guided by symptoms. Okay. All right. In terms of non-pharmacological management, weight loss is emphasized in both the ESC and the American guidelines. There are multiple studies, and all of them have showed improvement in quality of life with exercise in these patients. And in terms of device therapies, an implantable pulmonary arterial monitor was shown to have 50% reduction in heart failure hospitalization. Okay. All right, so the key takeaways, HFpEF is often under-recognized, mainly because most people don't know how to diagnose it, leading to misdiagnosis in many patients. And when HFpEF is suspected, you need to utilize the H2FpEF score, which includes it's actually 2 non-clinical variables for assessment. And heart failure with preserved ejection fraction is a diagnosis of exclusion. So you always need to rule out other conditions that mimic it, especially amyloidosis. And in our setting, constrictive pericarditis. Okay, well, thank you. All right. All right.